Today, I will be discussing functional medicine and metabolomics. So a little bit about myself. I am Dr. Greg Nacarelli. I am a naturopathic doctor, and I have a PhD in genetics and genomics. I work for Therium. I am a precision health consultant and clinical success manager. And overall, I've been practicing in natural medicine for over 10 years now. And I decided to do a foray into genetics and multiomics because I believe in improving the precision and personalization of medicine. And as we'll discuss throughout this presentation, there's a lot of issues with conventional medicine as is currently contrived. Even natural medicine is imprecise in the way that it is recommended. And there's ways that we can improve the precision of our treatment recommendations by using modern day technology. So natural medicine is awesome. It's been around for a very long time, but modern advances in science have allowed us to kind of avoid some of the current pitfalls with it. So we'll be getting to that in our slide. Okay, so some of the topics I'll be discussing, I'll be mentioning reductionism versus systems biology. We'll be talking about some issues with conventional medicine. And then we'll talk about functional medicine in terms of some background information, and then we'll go through some of the functional medicine frameworks. And then we'll talk about metabolomics in terms of the background, some relevant metabolites to functional medicine, and then types of testing. And then I will be giving some examples of using functional medicine and metabolomics. Okay, so the current US healthcare system model is reductionist. What does this mean? So reductionism is essentially looking at individual components. It's very disease-driven, so it essentially assumes that diseases are almost in isolation. You have somebody with diabetes or with cardiovascular disease or with an ankle injury, and is not necessarily looking at the individual associations between the two. If you have a ankle break, you go and you see a orthopedic doctor. If you have autoimmune disease, you go to a rheumatologist or an immunologist. If you have a gastrointestinal issue, you go to a gastroenterologist. So you're not necessarily seeing a practitioner that's going to be connecting all of those, at least as is currently contrived. So the reductionist approach is in contrast to the system science approach. So with this, it views our body and our organs and even pathways in terms of systems that are interconnected. And so when you view things this way, it allows for further individualization and allows for extrapolations between these pathways to find these interdynamic relationships. And by doing this, you're able to treat kind of the whole rather than just reducing it into its smaller components. So what are the issues with a healthcare system that is more reductionist in nature? So there's many different issues. As we could look at cardiovascular disease outcomes, we could look at diabetes risk, we could look at cancer. But if we look at it from life expectancy and also health expenditure, as the graph on the right is showing, the United States spends the most in healthcare compared to all other developed countries and has the lowest life expectancy. So something's going on there. We spend the most in healthcare and we get the least in terms of improving our life. So that's not good. In the United States, 50% of adults have at least one chronic health condition. 25% of adults have 2 or more chronic health conditions. 1 in 2 will get cancer in their lifetime. Alzheimer's disease is skyrocketing. You look at childhood diseases, that's also skyrocketing. Autism rates are increasing. And 86% of healthcare spending goes towards chronic diseases. So there's something that needs to be looked at in terms of we're spending so much on chronic diseases, yet it's just going up. So what is going on here? Why is this a problem? Or what is the problem with this? So conventional medicine is reductionist in nature, like I mentioned. It is very costly. It's also possibly harmful. So that in 2016, there was a epidemiological study done by Johns Hopkins, which looked at the causes of death in the United States And oftentimes, if a surgical procedure goes wrong or someone has an adverse medication that results in harm, there's questions around, is that documented properly, even charted, or even on death certificates? But when you calculated that, incorrect prescribed medications or surgical mishaps or wrong diagnosis was associated with the #3 leading cause of death in the United States. I was in medical school when I came across this, and it was kind of profound to think that our healthcare system, which is supposed to promote health, is the #3 leading cause of death in the United States, which is pretty shocking. At least at the time. This was in 2016, so I don't know where it's at now, assuming that things are, or seeing that health outcomes are getting worse and we're spending more. I don't see why that would be drastically different. But so that's a problem. So arguably, the current medical system is harmful. It is largely predicated on medications and surgery. And within the context of what I will describe as functional medicine, medications do not necessarily restore function. And so perhaps that's something we can improve. Overall, the conventional medical system is not working. I was in a meeting with at a medical school somewhere else in California, and this topic was brought up amongst other doctors, and their solution was that it's not from the approach, it's not from medications or surgery, it's because people aren't taking their medications. And so their workaround for this solution was to create tracking devices that people could like take or swallow that would be able to signal to their practitioners if they had taken their medication. So it wasn't, perhaps medications is the way. It's, we need to make sure they're getting meds, we need to increase their meds, and we need to track their meds. And I'm sitting there thinking, well, what if they're not taking the tracker? Do we track the tracker? Like how ridiculous does this get? Anyway, so that's one way to think about it. The other way, so Rita Mae Brown or Albert Einstein, it's kind of controversial who came up with this quote, but insanity is doing the same thing over and over again and expecting different results. With the way the system is currently set up, how are we going to decrease this chronic disease burden in the United States and improve health outcomes? The current way of doing things seems like it's not working, so there needs to be a different, better approach. Enter functional medicine. So functional medicine is a systems biology approach to medicine, in that it's looking at the interconnection of various systems in the body and how they are associated with health. Using functional medicine in practice involves using a functional medicine framework, and this framework involves restoring function. So that's the whole premise. As you could see on the right here, there's many different disciplines that underlie functional medicine, looking at dietary, lifestyle, environmental exposures, nutrition, signs of malnutrition, evaluating biomarkers, evaluating metabolic pathways and networks, looking at things through a systems biology lens. This originated in 1900s. There was Sir James Mackenzie, who was in Scotland working at a clinical institute, and he wanted to see if there was a way to treat his patients who had underlying pain and fatigue by looking at things through entire systems rather than just symptom management. And he wrote this in his book that restoring function might be one way to help these individuals. Since then, natural medicine evolved, and the Institute of Functional Medicine, which was the more formalized training for functional medicine, was started by Dr. Jeffrey Bland, who was my commencement speaker at my medical school. And it's since taken off since then. So to practice functional medicine involves utilizing something called a functional medicine matrix, or at least getting familiar with it. So the functional medicine matrix outlines the systems and the areas of which a functional medicine practitioner is looking at. So things are viewed within the context of antecedents, triggers, and mediators. The antecedents, these are predisposing factors. They could be genetic, they could be an in utero environmental exposure, things that essentially are early lifehood, generally speaking. There's the triggering events. These are things that have a distinct start and finish. That could be predisposing somebody for illness, for example. They got into a car accident and they haven't been the same since. And then there's mediators, perpetuators, these things that are ongoing and contributing to poor health states. such as continual stress at work, things of that nature. Within the functional medicine systems, there are 7 key systems. So there is assimilation, which is essentially digestion, absorption, respiration. There's defense and repair, which we would traditionally call inflammation or immune function. Energy, we're looking at mitochondrial function. Biotransformation and elimination, we're looking at detoxification. Transport, we're looking at cardiovascular and lymphatic system. Communication, our neuroendocrine system. And then structural integrity, from subcellular membranes to musculoskeletal structure. In the middle of the functional medicine matrix, we have our mental systems, which refers to cognitive function, perceptual patterns, emotional domain here, which refers to emotional regulation, grief, sadness, happiness, and then spiritual. So does somebody, are they in touch with their spiritual side? Do they have meaning? Do they have purpose? And then we have modifiable lifestyle factors at the bottom here: sleep and relaxation, exercise and movement, nutrition, stress, and relationships. So what a functional medicine practitioner can do is fill this out with relevant information from their patient intake, patient interaction, and try to identify the areas of dysfunction. So for example, this is cardiometabolic matrix. So for the most common issue in the United States today is cardiometabolic dysfunction. There's lots of different areas that we could look at within the functional medicine matrix. So for example, for their antecedents, certain genders are associated with increased cardiometabolic risk, their ApoE status, so in terms of genetic inheritance, family history, cardiovascular disease, triggering events, so did they have an infection, did they have a toxin exposure? For mediators or perpetuators, do they have chronically elevated insulin? Do they have chronic oxidative stress and inflammation? For their assimilation, do they have low stomach acid? Do they have dysbiosis? For defense and repair, do they have chronic infections? Do they have elevated markers that are associated with inflammation? For their energy, do they have low glutathione? Do they have elevated oxidative stress? Are they on medications that could be decreasing things implicated in energy production, such as CoQ10? For biotransformation and elimination, do they have certain toxin exposures, persistent organic pollutants? Is their homocysteine elevated? Do they have diseases associated with impaired detox, such as non-alcoholic fatty liver disease? For transport, how is their arterial system? Do they have dyslipidemia? Do they have elevated blood glucose? Do they have endothelial dysfunction? For communication, looking at the endocrine system, how's their thyroid? How's their pancreas functioning? For structural integrity, so do they have elevated, or do they have an elevated BMI? Do they have arterial inflammation? Do they have elevated coagulation markers such as fibrinogen? So you could look at all these in terms of the functional medicine matrix, writing these down in terms of what's applicable to your patient. You could look at sleep and relaxation. So do they have sleep apnea? If you're using biometric devices, what is their heart rate variability on average? Exercise and movement, do they sit a lot? Are they sedentary? For nutrition, do they have a high glycemic load with foods? Do they have a high sodium diet, high processed food diet? Do they have low nutrient diversity? For stress, do they have a history of abuse? Are they anxious? Do they have financial stress? Do they use drugs and alcohol? And then in terms of relationships, are they isolated? Do they experience grief? And all these things obviously will be connected with the mental, emotional, and spiritual domain as well. So this is one way to view a functional medicine visit, is to apply the applicable intake information here. To better outline the antecedents, mediators, and triggers, one thing that is done is this functional medicine timeline. And so essentially you could look at it preconception, prenatal, and then through birth, and then from then until now, what are the current concerns or issues that the individual is experiencing? So, for example, preconception, family history of IBS and diverticulitis. They had a vaginal birth, but then they were prescribed antibiotics, or the mother was, due to membrane rupture. This individual was bottle fed at 4 weeks, which could predispose them for health issues later on down the line. Colic at 6 weeks, tonsillectomy, some stressors, their parents divorced, At age 10, they experienced abdominal pain. They were diagnosed with lactose intolerance. Gave birth to 2 different children, experienced postpartum depression, leading up to their current concerns, which is gas and bloating, frequent non-bloody stools, and just a sensitive stomach and overall feeling of low energy. So this is one way just to kind of map out the health history of the individual. And especially when people will say to you, I have not felt well since. This becomes especially important to figure out, okay, what was this event? When did it occur in their life? And what was leading up to that event and what happened after? And this could be continually filled out to track the resolution of concerns and if new ones arise. There's also the Go To It framework in functional medicine. So Go To It stands for, the G is gather, that being oneself and the information provided. Organize the information in terms of subjective and objective details. The T is tell the story back to the patient, therefore verifying that you have the information correct. The O is ordering the steps by the level of importance. I is to initiate assessments and interventions, and the T is to track the effectiveness of the interventions. And so within this, you're looking at the chief complaint and medical history, which will be associated with many different symptoms. The conditions, you're tracking the conditions by the system, via gastrointestinal or immune inflammation or mood disorders. Tracking the medical history, the antecedents, triggers, and mediators in terms of those. Anthropometrics, biomarkers, and labs. Performing a nutrition physical exam to determine what nutritional or what findings may be associated with nutritional deficiencies or nutritional excesses. Diet and lifestyle associations, and then looking at functional medicine matrix patterns in terms of which systems require the most awareness for investigating. There's also functional medicine dietary plans. There's core plans that are more generic for people, whether they're vegan, vegetarian. There's first step intervention plans. This would be the elimination diet, which is recommended to individuals with possible food sensitivities or allergies. There's the cardiometabolic food plan that is recommended to individuals with cardiovascular disease or metabolic dysfunction, or I just like it in general, to be honest, because it's just very all-encompassing in terms of it's an overall healthy dietary plan. And then there's more advanced therapeutic interventions. So there's a low FODMAP food plan for people with possibly SIBO or FODMAP sensitivity, the anti-candida food plan for individuals with candida overgrowth, mito food plan for mitochondrial function, and then there's the detox food plan for optimizing detox. There's the ABCDs. So within this, there's anthropometrics and vital signs, biomarkers and functional labs. The C is clinical indicators from the nutrition physical exam, and D is diet and lifestyle review. So within this, I'd like to focus on this biomarkers and functional labs. And so the question being, for identifying function versus dysfunction, what is an ideal lab to use? This is where metabolomics can come into the picture. So metabolomics is one of the omics fields. To start, we have our DNA, and the study of which is genomics. This will be transcribed into RNA, and the study of that is transcriptomics. And that will be turned into proteins, and the study of which is proteomics. And then these proteins form our metabolites, the study of which is metabolomics. Metabolomics is highly influenced by our environment. It's kind of the further down this stream we get, the more influenced by our diet and our lifestyle. Our metabolites will shift and change. So why look at metabolites? They're more upstream from the rest of our cellular components. So you have molecules, which then will combine to form macromolecules, which will then eventually combine to form cells, tissues, and eventually organs. Doing scans of somebody to wait till we see pathological changes in the organ, for example, or liver fibrosis, though the liver can regenerate, when we reach that point of structural changes, it's very hard to intervene and elicit changes. Versus if we look more upstream, by looking at the molecules, we could see how the molecules are shifting in response to our diet, our lifestyle, and our genetic predispositions. And we could intervene earlier before we get these more pathological changes later on. This pathway is accessible. So if you type in Stanford Medicine Pathway of Human Metabolism, you can get access to this lovely diagram. This is all the metabolic pathways in a human. And obviously not going to go over all these, but I show this to demonstrate just how incredibly complex it is. But if you notice, a lot of them are interconnected. We have, long pathways that are just all sort of connecting with each other at various different branch points. They're not all isolated, which is sort of the rationale behind systems biology is this is working in concert, often in the same cellular components with each other. So major metabolite pathways that you could look at in order to establish an understanding of an individual's metabolism. So glycolysis, which is breaking down sugar, gluconeogenesis, breaking or converting amino acids into usable forms of energy, pentose phosphate pathway to generate NADPH, citric acid cycle, oxphos, this is within our mitochondria to generate energy or ATP, fatty acid metabolism, so making it, breaking it down, forming ketones, urea cycle, or our ability to get rid of excess nitrogen, nucleotide metabolism in order to make our backbone for our DNA, amino acid metabolism, one carbon metabolism, this is the methylation cycle I discussed last week, heme metabolism for red blood cells, and then detoxification. So these are just some major metabolite pathways. From these, we could get inferences into many areas of health. We could get glimpses into aging, nutritional status, inflammation, mitochondrial function, cardiovascular function, reproductive, liver health, gut health, neurocognitive health, integumentary health, environmental toxicity, mutational load, just to name a few. But these metabolic pathways are underpinning our biology. So in theory, they will be having a role in all of our health and disease states. And so how do metabolomics and functional medicine fit together? So metabolite patterns can serve as key indicators of function in an individual, and abnormal metabolite concentrations or pathway imbalances can indicate the presence of dysfunction at some point of that pathway. And so by understanding this, we could figure out, okay, what interventions can we use to target which metabolic pathways to restore the function? And then most importantly, we could then look at global metabolite changes via metabolomics to see, okay, based on this imbalance that we're now addressing, did it correct the pathway dysfunction? And by doing this, we could give us clues into what are the next best steps or the next best interventions in order to continually try to restore function to the individual. So we could look at some examples of key metabolites that are associated with various different functional medicine domains. So for example, for assimilation, we could look at indole acetic acid. This is a breakdown product of tryptophan in the gut. We could look at putrescine, which is a polyamine formed in the gut. It's conserved in an antioxidant. It's lower, that's not good. Tryptophan, which is an amino acid necessary for serotonin production. So you could look at these to assess assimilation. Now, this is part of the gut section in the Therium Aristotle report. All these metabolites I will mention are metabolites that Therium tests for in their metabolomics test. For defense and repair, we could look at deoxyadenosine, which is a component of DNA in which high levels will impair immune function. We could look at histamine, which is involved in immune communication and in certain situations where it's in excess, that's not good. Palmitic acid is a saturated fatty acid, high levels of which are associated with inflammation. For energy metabolism, we're just looking at essentially TCA cycle metabolites. And so citric acid, fumaric acid, alpha-ketoglutarate are involved in the TCA cycle. And if these levels are either too low or too high, that could indicate imbalances in the mitochondrial function. Biotransformation elimination. So we're looking at metabolites associated with detox. There's pyroglutamic acid, which is a precursor to glutathione. So if these are off, that could indicate disruptions in detoxification pathways. There's ornithine, which is involved in the urea cycle. And if that's out of range, that could be associated with impaired ability to remove excess nitrogen. For transport, so you're looking at things that will impact cardiovascular function, arteries, blood vessels, lymph. And so taurine is an example of a metabolite that's involved in many different bodily processes, and especially associated with important vascular function. Adenosine will associate with cardioprotective benefits and will impact blood vessel dilation. And then homocysteine being one of the major metabolites in the one-carbon metabolism or methylation cycle. If this is elevated, this could indicate cardiovascular dysfunction. Communication. So we have some serotonin-related metabolites, and then serotonin could go down, or at least tryptophan can go down this pathway where it's converted into this pro-inflammatory metabolite. So do you have enough of the beneficial neurotransmitter, at least not in excess, which can also disrupt gut function? Do you have excess of this pro-inflammatory metabolite, which is often associated with excess oxidative stress or inflammation? And then GABA. So this is a neurotransmitter involved in reducing neuronal excitability. So where's somebody at with their excitation? And obviously there's other metabolites you could look at that are associated with this, but these are just some key ones there. And then structural integrity. So 4-hydroxyproline is an amino acid found in collagen production. Ethanolamine is a compound of phospholipids in cell membranes. If that's low, that could indicate some issues with not just cell membranes, but potentially detoxification as well. And then glycine, which is one of the backbones for collagen production. And so these are integral in associating or assessing structural integrity, found in the integumentary section in the Aristotle report. So, all right, some key takeaways here. Functional medicine is a systems biology approach to managing chronic disease that focuses on identifying the sources of dysfunction in the human body. And metabolomics is a field of science that assesses collections of metabolites and associates them with various health and disease states. And by using metabolomics in functional medicine clinical practice, we can assist in identifying areas of dysfunction, and then also we could figure out where to intervene next in our treatment plans to optimize the function as well. So that's what I have today in terms of metabolomics and functional medicine. If you would like to chat with me one-on-one to discuss using metabolomics in clinical practice, be it functional medicine or other, there is a link here. For now, I will open it up to Q&A.
Hey, Greg, it's Vishal. Just wanted to thank you for the good discussion as usual, really informative talk. I'm not currently practicing functional medicine and don't have patients of my own in the functional medicine space, but certainly some good implications of where we need to, be going in terms of the current landscape in healthcare and how we need to be thinking about certain chronic diseases. So thanks for that.
Absolutely. Yeah, I think it is a very exciting. So, there is the IFM Institute for Functional Medicine. And since that kind of started to blow up, I would say within 10 years ago, it started to accelerate. There's been all these other functional medicine spin-offs. And so the next stage for functional medicine is they are now going to, there's a overall regulatory body that is going to certify people in functional medicine, even if they have not done the quote unquote IFM functional medicine training. Because it's now going from just something that this institute had or Jeffrey Brand started versus just a form of medicine. And that's kind of a next step in this type of medicine being more adopted systematically within the United States and the rest of the world. I've encountered many practitioners from other countries that are practicing functional medicine. There's various institutes that are also looking for, or I should say even universities that are looking for functional medicine trained doctors. So I think this movement of getting this type of medicine into mainstream is actively occurring. And Therium, being a metabolomics company, is well positioned to be a functional medicine provider for functional medicine testing. So the regulatory body, so I believe it's in the process of being recreated. So functional medicine, they're pausing their certification process to to sort of comply with this. And so I believe in 2026, they will be certifying people via this methodology, that being not just IFM certifying people, but anyone that has done the or has met the criteria for being functional medicine certified. They're also separating it based on, because before it was kind of loose guidelines in terms of who could get certified as a functional medicine practitioner. They're now splitting it off between health coaches and medical providers. And so MDs, DOs, NDs, DCs, physician assistants, I think pharmacists, and then nurse practitioners can get this medical track. And then everyone else, which is like health coaches and nutritionists, will not get the medical track. And I think it's, for this process, I think it's important to distinguish like who are healthcare providers versus who are not. So, and I think that's one thing. When you say they are, I guess the regulatory body, I don't know if IFM is doing this, but the regulatory body that is setting this up is making this distinguishment. What was the certification process like? I have not done it yet, but I have done functional medicine training. I'm about halfway through my functional medicine training. The certification process involves, well, at least going through IFM, it is 6 courses. So it is a course on there's a bioenergetics course, gastrointestinal health course, environmental health course, cardiovascular health, immune health, and then hormones. So those 6 modules, each I think it's like 3 days long. And then there is the applying functional medicine in clinical practice, which is essentially just foundational stuff, nutritional exams, clinical nutrition, major disease management, or I shouldn't say major disease, but common diseases like, I don't know, cardiovascular dysfunction, immune dysfunction. And so you do all that course training, then you submit case studies that you've used this functional medicine practice, or this functional medicine framework in clinical practice. And then there's a board exam that you take so that you are certified in functional medicine. That I think that process may change a little bit in the future when it's when this new board is created, but for now that's the current framework. Excellent, Nicholas. I say you just joined. So, thank you for mentioning that. So, okay, we have a question here. With respect to this testing, under what conditions can we expect peak accuracy, and under what conditions day of prep can accuracy suffer for these tests, generally speaking, based on certain organs not being functional? So, oh, okay, no worries, Nicholas. We get questions like this every week regarding like very specific questions in terms of like accuracy, specificity. We do have a blog post on that, or we will be releasing one soon. So I do want to defer to that in terms of accuracy. Generally speaking, our metabolism there should not be drastic shifts. Okay, if you're looking at hormone metabolites, it's going to be different. We're for our Metabolomics test, at least as is currently designed, we're not looking at hormone metabolites. Some of these other ones, now, if you're doing a 3-day long fast, it's going to be different. So when we're recommending the Metabolomics test, it has to be indicative of your current health state. So don't drastically change your diet. Don't drastically do a fast. Don't drastically do a detox. Don't take a bunch of supplements. Don't remove all your supplements. So based on what you're currently doing, what is your metabolome? That's the best way to do it. And so at least when I'm recommending people to do this test, it's it's done first thing in the morning before you've taken supplements on an 8-hour fast, and that's the most ideal way to assess it. And the samples are run in triplicate, so within one sample, we are looking at various different assessments of that sample, and so yes. Now, when you're looking at, so our test looks at 126 different metabolites. What is sensitivity, specificity, each metabolite? I can't give you that information. But If somebody has more technical questions such as that, I would suggest to reach out to our Chief Scientific Officer, Dr. Panise Jaspi, who may be able to relay that information. I'm more the clinician person here. I'm not so much the technical science person. So yeah, I will defer to that. We have another question here. The metabolites is indicative of metabolic pathways that are in need of assistance to be added or removed to keep the flow going in the right direction. Absolutely. And so, and what you'll see with evidence of dysfunction is you'll see impaired metabolite pathways. So for example, with mitochondrial function, you'll see some mitochondrial intermediate metabolites are elevated, and then some metabolites are low. You might see a block in a pathway, in which case you'll see a metabolite increase and then its subsequent downstream precursor decrease. And so there's something there that's blocking that, and that's what you could identify from metabolomics. I mean, there's so many different points of things that you could see from the metabolomics. It just depends on the metabolic pathway that you're looking at. And they are associated with various different disease states, which is where, I mean, the science is kind of taking off in terms of looking at not just individual metabolites, but metabolite pathways and extrapolating them towards health and disease states. And so it is a active area of research currently. Yeah, so if somebody was fasting for 16 hours versus 8 before doing metabolic test, would we expect the results to be different? Well, let's say like for glycolysis, gluconeogenesis, after about 24 hours, we depleted our glycogen. But let's say somebody was more, more glycogen depleted, we might see shifts in glycolysis, gluconeogenesis, fatty acid metabolism, just to name a few. And that would be just by doing basically doubling the amount of time that they would be fasting. We're not measuring hormone metabolites, but you would start to see fluctuations in that in terms of cortisol for trying to improve the blood sugar. So we would be seeing some differences with that, yes. Fatty acid concentrations, I guess it will depend. I mean, if you've had somebody that has been eating a certain type of dietary spectrum of fatty acids, like, palmitic acid, I don't expect that would be too different. So it just depends on how long the fast is. But generally speaking, we wouldn't recommend somebody to do a prolonged fast before doing this test. So another point here, assisting the body to repair itself as opposed to symptom suppression. Okay, well, they match up to the metabolic chart from Stanford, assisting the body to repair itself as opposed to symptom suppression in Western medicine. It's more of what you need, less of what you don't. Yep, absolutely. This is where everyone has individuality. Our genetics will impact our metabolic pathways. Some people may make more of a metabolite, make less of a metabolite. Then we have environmental influences. And so what is somebody getting from their diet? If they're chronically stressed, that's going to be depleting metabolites or upregulating certain metabolic pathways, downregulating other metabolic pathways. That's why I really, in assessing functional medicine is really all of those areas, there's associated metabolic pathways. They're both systems biology. So functional medicine and metabolomics are both systems biology. And so this is sort of the approach. They are very interconnected in terms of even lifestyle medicine, preventive medicine. But we also have, I almost feel like they're simultaneously, we have the conventional medicine field and how it's been operating. I mean, there's been so many advances in different metabolites or biomarkers that are associated with health and disease states. And for whatever reason, usually these metabolites are not considered as heavily, at least in my opinion, unless there's sort of a druggable target for them. And so, like looking at something like ApoB, where it's arguably a better, I shouldn't even say arguably, it's unequivocally a more indicated or powerful indicator of cardiovascular disease versus something like LDL. But it's not readily run, it's not readily covered, at least in my experience. So at what point does the conventional medical field start to put more emphasis in these powerful metabolite predictors of disease? This gets into like the regulatory aspect of things, which I am not that familiar with. I don't want to be familiar with it, but I guess I see the problems and I realize that, really you have to change policy in order to elicit these changes. by and large, but it's hard to do. I'm guessing it's hard to do. Okay, we have another question here. Are there other categories of functional medicine tests that you find often do not match up with metabolomics tests? If so, what would account for those differences? So there's many different types of tests. Like, for example, there's antibody testing. And the antibody testing could be hit or miss itself. So looking at IgG immunoglobulins or IgE immunoglobulins. And so, when you're looking at that versus there are metabolites that are associated with inflammation. And so we have our immunoglobulins and what they're specific for. Are they necessarily associated with those items that are causing inflammation? And then we could look at metabolites that are usually upregulated in response to inflammation. For example, I was mentioning palmitic acid. And so, there is sometimes a discrepancy there. There's gut tests. But gut test is getting out of the wheelhouse of, metabolomics. It's more getting into the microbiomics. But around 50% of our metabolites are going to be impacted by our gut microbiome. And that really is the holy grail, is to find the interconnections between the two. So if you're looking at the genome, you're looking at the metabolome being the metabolites, and then you're looking at the microbiome. How are they associated with each other? And we're just getting there in terms of medicine to be able to do this multi-omics approach where you're looking at the associations between microbiome metabolites and microbiome strains of microbes that are present or lack thereof, and then how that's impacting the metabolome. So, this is an active area of research to look at between tests, how are they associated? And again, this goes back to that systems biology approach. And this is just, far removed from the way medicine conventionally operates. And so this is really what we're talking about, is the future of medicine, the future of health and wellness and medicine. Okay, so we have another comment here. Genes are the blueprint, but may or may not be expressed. But Bob Miller from the Nutrigenetic Research Institute said, assist the pathways, don't treat the genes directly. You don't know if they're expressed or not. That's why genetic testing hasn't taken off, because they treat the genes, not the genes expressed. Bob Miller is like 50 minutes away from me. I got to go meet this guy. I feel like someone every week mentions him. I've not met him yet, but yes, no, I think that's a really good point. By just looking at genetics is the potentiality, and it's associated with health risks. It's not necessarily the outward expression of a health risk. Usually, there are some genetic conditions that are so severe that by assessing the genes, you know that you will have that condition, and then you could predict what the future will be in terms of like cancer risk, right? You could look at BRCA1 mutations with like 60% of the time at a certain age, a woman will have breast or ovarian cancer. So some genes are more serious than others, but by and large, that's why they call them SNPs. For something to be a SNP and not a rare variant, it needs to occur in 1% or more of the population. So by definition, those SNPs, they're not rare. But these rare gene variants are, possibly causal. But yes, it's conferring a percent risk, and you will see that risk manifesting in a pathway. So for example, with last week, we covered methylation. There's the MTHFR gene. There are risk variants in that gene where it's less efficient at making methylated folate. What you would then see is disruption of the 1-carbon metabolism pathway. So you'll see less methylated folate. You'll see increased possibly methylmalonic acid. You'll see increased homocysteine, decreased methionine. And if you hear a car alarm, it's going off outside. But so they're interconnected. In an ideal world, you look at it all and you use artificial intelligence to find extrapolations between those different omics fields. But yes, it's definitely important to look at both. We got to get Bob Miller to take a look at therium. I feel like he might be interested in our test. Can you compare contrast therium, how it impacts your practice versus other organic acids? The therium test includes organic acids. Granted, in a tradition, I won't name names, but in certain other organic acid tests, they're looking for metabolites of other microorganisms, for example, Candida. And so actually, I don't want to misspeak. Let me verify that. I don't think the Aristotle test. Oh no, I lied. We do include arabinitol. Okay, so we do include we include many of the similar metabolites that are included on an organic acid test. We don't include some of these like dopamine metabolites. We will in future iterations of the test. So it's similar in terms of the things that it's looking at. Uh, and we do look at more metabolites than the I guess the most common organic acid test. So I would just say the Ethereum Aristotle is the name of the Ethereum metabolomics test. Looks at more metabolites than just an organic acids test. I would say the organic acid test, it's largely focusing on the gut, but it has other health extrapolations as well. Okay, we have another question here. Nutrigenomic testing matches very well. It's what the genes are, and then metabolomics sees what is being expressed. Yep. That's why I don't agree with Gary Brecka. He says, if I have this gene, then do this. I tried contacting him about it. No response. Yeah, I do agree that Gary Brecka, I think he's overstating the importance of genetics. Probably because he has a company that involves genetic testing. So hey, look, he's getting people to realize that at least one of the omics fields, and so for that, I applaud it. I think it's great. Get people to be interested in that. I feel like genomics or the SNP testing is like a gateway drug to the rest of the omics world and metabolomics and proteomics and microbiomics. So whatever gets people interested and aware beyond that of just conventional medicine, I think it's great. But there's a lot more than just looking at genetic predispositions. So, okay, we have another question. What could be the reasons why results would be different on metabolomics tests versus other types of functional tests? You know, as a general rule, if I'm running tests on somebody, especially if I'm going to retest, I always use the same company because just between different lab instruments, lab testing technology, like even Quest versus LabCorp, like you could get different readings. And so when someone comes to me and they're like, well, I did this test on this one test, and 3 months later I did this and the values are off. If it's a different lab company, I automatically question it from the get-go. So there's that. Like if it's the same metabolite. When you're let's say it's different metabolites but different health areas, then it comes into okay, how is that company assessing for some health concern? Let's say it's inflammation. I know at Therion we use artificial intelligence to find extrapolations between metabolites and metabolite pathways in order to indicate how these health domains are. The way I was taught this is, as a clinician, we learn individual metabolites and how they're associated with certain health and disease states. But our body it's not working based on one metabolite. It's working in terms of a network. And so you have to look at the entire network. But the entire network it's varied. You have one metabolite's high, this one's low, and this one's normal. And then you have when you do that on a scale that's like 100-fold, how do you know when this one's high, this one's low, this one's normal, this one's high? Like, how does your brain calculate to figure out what the next best step is? This is where artificial intelligence comes into play because it could find those extrapolations. And then there's the machine learning aspect of this. I covered this in, I think it was two webinars ago, where the machine learns from this process as well. And so over time, the artificial intelligence gets better at these predictions. And so I would say that's important. So one, making sure that you're not going between entities sticking with the same company for doing your test. And two, that you trust that the entity with the readout is doing the readout properly because that could account for some discrepancy as well. But look, as a clinician, I always say common sense as well. Like, you don't want to intervene and do something drastic, especially if somebody is healthy. And on the flip side, if somebody is diseased or ill or dysfunctional and you see something glaring and yet the test is saying, well, you should be fine. It's like, well, you still have to help them, right? So at the end of the day, use your common sense to make sure that we're in the, you're in the, you're doing this to help people. So make sure they're happy and feeling like they're being helped and heard. And that's kind of how I feel like artificial intelligence allows us to be first and foremost healers and creating a space to sit with people and listen to them and understand them. And then we could allow the technology to do all the other the data crunchy stuff. Okay, someone tried calling Bob Miller, no response, want to sign them up. No response, yeah, get them, have them connect with me. I've spoken with some, there's a lot of interest from varied practitioners, let's put it that way. Thank you, Vishal, to something I said earlier, couldn't agree more. Conventional CBC, hormones, allergy, etc. are good because they say what is, but it doesn't say why. Yep, metabolomics shows a flow diagram, really what's blocked and potentially why from connecting other metabolites. Yep, metabolomics is the most advanced metabolic flow chart that has ever been created with analytics for accuracy. Absolutely, couldn't agree more. Completely agree, not just treating their lives. Yep, absolutely. Well, it sounds like we're mostly all on the same page. So I'm glad we're all on the same page for metabolomics. And so yeah, so if anyone is interested, again I'll drop the link in the chat here again. Anyone wants to meet with me to talk with me about this one-on-one, let's say you have a patient case, or let's say you're interested in metabolomics in general or the Therium test, jump on my schedule. We'll have a conversation about this and we'll go from there. But otherwise, thank you so much everyone for attending.